Assalamualaikum. So I'm Ali Jafri. I'm also a community oncologist. So it's really nice to be here in front of so many experts. Thank you to the HOPPE community for having me here. In our practice, so we're a little bit more than 100 miles from here. We see quite a bit of different solid tumors, and one of them in particular is renal cell carcinoma. So basically, I'm going to be talking about different TKI-IO combination therapies, go over some evidence based on them and some considerations. Renal cell carcinoma, it accounts for about 4% of adult malignancies. About 30% of patients do present with metastatic disease, of which clear cell histology predominates. So the VEGF pathway promotes angiogenesis or drives angiogenesis, and PD-1, PD-L1 axis mediates immune invasion. So VEGF TKIs, they remodel the tumor microenvironment, enhance T-cell infiltration, and synergize the checkpoint blockade with checkpoint blockade. So there's combination IO, TKI, and IO-IO. They've become the standard first-line approach. So we do use IMDC risk stratification and stratify patients into favorable, intermediate, and poor risk based on their performance status, the time to diagnosis, from diagnosis to treatment, and their laboratory values. So risk group guides first-line therapy options as per ASCO and NCCN guidelines. So first-line therapy options in the clear cell across all IMDC risk groups. So these are axitinib and pembrolizumab, cabozantinib and nivolumab, lenvatinib and pembrolizumab, and then the dual IO checkpoint inhibitor ipilimumab and nivolumab. Additional preferred in the intermediate poor would be cabozantinib monotherapy. This was the KEYNOTE 426 trial of pembrolizumab and axitinib. So benefit was seen across all IMDC risk groups for progression-free survival and objective response rate. This was phase 3 compared to sunitinib. And the benefit in OS was seen at the 5-year mark in the intensive treat population. So you'll see here median duration response about 24 months versus 15 months for sunitinib. The toxicities were a little percentage higher with the combination regimen. Checkmate 9ER was nivolumab plus cabozantinib. Over here we saw a durable benefit at the 5.6-year final analysis. They actually showed the dual inhibitor TKI-IO had more healthcare-related quality of life was better versus sunitinib, and the 60-month PFS rate was a 10% delta favoring the combination. So over here you can see the response rate of 55.7% versus 27.4%. There were some more grade 3-4 toxicities. The CLARE trial was lenvatinib and pembrolizumab. This is, out of all the trials, has the highest objective response rate at 71% and CR rates at 16% among the TKI-IO combinations. So longest median PFS was seen about almost 2 years, 23.9 months versus 9.2 months for sunitinib. But it did have the highest toxicity burden, and so it did require frequent dose reductions or even dose discontinuations. At the end, the overall survival did converge, but there was thought to be confounded by crossover. So if you look at this, so there's no head-to-head data, and we cannot really compare across trial. But if you just look at the difference in similarities between the trials here, the network meta-analysis do suggest a trend toward comparable overall survival on these regimens, but quite high response rates and some CR rates there too. So practical selection for TKI-IO versus IO-IO. So TKI-IO, you're going to get higher response rates, rapid disease control, median time to respond less than 3 months usually, preferable for symptomatic high-risk disease, high-volume disease, but then they could have the more toxicity with the TKI. The combination dual checkpoint inhibitor regimen. So patients that do respond, they tend to get durable responses with this. And you do see high CR rates in the intermediate poor risk group. The dosing on it, 4 doses of ipilimumab followed by maintenance nivolumab is convenient, and you also avoid the chronic TKI toxicity. So factors that would favor IO-IO would be uncontrolled hypertension, because a lot of the TKIs cause like especially lenvatinib, cause like hypertensive urgency even in a lot of patients, hepatic dysfunction, bleeding risk. They would favor IO, whereas factor favoring TKI monotherapy over IO would be if you're on chronic immunosuppression with any active autoimmune disease, or if you had an organ transplant. So toxicity management, so sometimes it's hard to figure out which one is causing it, but TKIs tend to cause more hypertension, diarrhea, hand-foot syndrome, hepatotoxicity. We see more IO related with the colitis, hepatitis, pneumonitis, endocrinopathies. We know for IO, steroids are really effective. For dose modification rates, again, lenvatinib and pembrolizumab, about 69% of patients require dose reduction, and 29%, about 29% discontinued the immunotherapy in that regimen. Nivolumab, cabozantinib, about 56% required cabozantinib dose reduction. They're already a lower dose, by the way, on this. When you're with the immunotherapy, you're 40 milligrams daily versus a higher dose when you're single agent cabozantinib. So real world data also shows really significant grade 3 toxicities in the dual TKI-IO combinations. So subsequent therapy after the IO TKI, so NCCN recommended regimens that are there. One of the newer ones is belzutifan and lenvatinib based on the LIGHTSPARK trial. This one showed 50% response rate after immunotherapy, and it was compared to cabozantinib. Generally, you do not re-challenge with IO-based combinations. It's a category 2B recommendation. Sequencing depends on prior regimens and what kind of toxicities the patient might have had or continues to have. And you should always consider a clinical trial. Non-clear cell, not as well studied, less patients, less population of these patients with it, but some newer regimens were the lenvatinib, pembrolizumab, and ipilimumab, nivolumab. Again, clinical trial is strongly encouraged. So key takeaways: IO TKI combination category 1 preferred first line for metastatic clear cell RCC across all IMDC risk groups. All three demonstrate OS, PFS, and ORR superiority over sunitinib. Lenvatinib and pembrolizumab has the highest ORR CR rates, but also the highest toxicity. We have to select the treatment based on disease burden, comorbidities, toxicity, patient profile. No head-to-head data, and clinical trial enrollment is encouraged. So some of the things, I was just going to do a few slides on how I approach these patients in the community. So we face this question, patient sitting in front of you, we have 4 different really good options. Which one do we choose? So I look for rapid disease control. If the patient needs rapid disease control, what's their IMDC risk score? What comorbidities do they have? And what's the patient's tolerance for chronic daily oral medication versus a time-limited therapy? So again, these regimens I glanced at the bottom: ipilimumab, nivolumab, checkmate 214, PFS was about 24 months. But in this, again, people that get a response have a sustained response, and there's less adverse events in the dual checkpoint inhibitor. So a scenario would be a symptomatic, high volume, high burden patient. Maybe have a lot of metastatic disease to lungs, bone, liver, and there might be IMDC poor risk. So if you need, in this situation, you may need rapid disease control, so you would favor like an IO TKI combination. So I tend to favor lenvatinib, pembrolizumab because of the high response rates, but we have to also consider cabozantinib. Nivolumab is very good in this situation, especially if they have bony metastases. They've been shown to be better data in that. So again, some patients may get even a CR with these regimens. Favorable risk, low volume patient, these get a little bit tricky because you could also do surveillance technically. A lot of patients would think you're crazy though, sometimes they think you're crazy if you tell them surveillance when they have metastatic disease. But if you explain to them that active surveillance is actually a consideration as per NCCN guidelines also. So in this, IO is controversial because response rates were a little better than with sunitinib, but there are high CR rates. In here, I tend to sometimes consider axitinib and pembrolizumab just because the toxicity profile is a little better for axitinib. And you see consistent benefit across all IMDC risk groups, and so the lowest toxicity burden. Someone with significant comorbidities, so you have to look uncontrolled hypertension, you probably don't want to give lenvatinib. Consider ipi-nivo in those situations. Active autoimmune disease, we're limited by we can't give too much IO in that situation. Again, organ transplant. anyone bleeding risk, anticoagulation. So cabozantinib has specific GI perforation warnings. Again, you have to separate which one might be causing toxicities. And if you look at the bottom left there, the dose reduction rate is quite high in the cabo, nivo, and the len-pem groups, with some patients, almost 1/3 discontinue even immunotherapy in the len-pem group. So risk stratify with IMDC. Discuss TKI-IO with intermediate poor risk patients. Both are the IO and IO TKI are both valid. High burden usually favors TKI-IO. Have to manage their toxicity. Always consider clinical trial enrollment. And if they have oligometastatic disease, then definitely involved a multidisciplinary team. So all 4 IO-based regimen are category 1 preferred. Best choice would depend on the circumstances in front of you. And so IO TKI, rapid disease control, IO offers durable responses. So based on IMDC risk, disease burden, toxicity, so that's how we sort of decide. And proactively managing toxicity. At progression, different TKI backbone would be, you would sequence of that, and also consider clinical trials. These are references. Thank you so much. Thank you.